So what is hysteroscopy? Hysteroscopy is an endoluminal endoscope that aids to visualize the uterine cavity. And a number of intrauterine procedures can be done by hysteroscopy. So hysteroscopy is very important for us as gynecologists. And it may be a short procedure, but it's a much more dangerous procedure in terms of what can happen. Complications are much higher with hysteroscopy if we are not careful. So, what is hysteroscopy? Well, hysteros stands for the uterus, scopy stands for looking, and therefore it is trying to look at the uterine cavity from the inside. We have both diagnostic hysteroscopy and we have therapeutic or operative hysteroscopy. So the indications for hysteroscopy. Why do we think we may need to do hysteroscopy? Number one, it could be abnormal uterine bleeding. So let's say anyone with bleeding that we cannot explain and it's abnormal might have a cause intrauterine that we may want to look at. Subfertility, when you've done your treatments, things are still not working out, may need to be looked at by hysteroscopy. Recurrent pregnancy losses, lots of causes intrauterine are there that can cause hysteroscopy to be needed for a cause of recurrent pregnancy loss. Could be a uterine anomaly, could be Asherman syndrome, could be a polyp, could be a fibroid that is submucous coming inside. So they can all be related to pregnancy losses. It could be preoperatively as well. When we are doing, let's say, myomectomies, I always do a diagnostic hysteroscopy to see if there are any cavity issues before we proceed and go and do the operative myomectomy laparoscopically. It could be to a removal of objects that might be lost in there, like IUCDs, could be some bone fragments from a previous surgery, probably botched up termination or an incomplete evacuation. Could be products of conception that were left behind and are stuck. Could be placental tissue that was degenerated and got stuck. And we could use it for sterilization. So you can see it's a very vast possibility of what we can do with hysteroscopy. I told you hysteroscopy might be a short procedure. Frankly, most hysteroscopies take me less than 10 minutes, okay? And most diagnostic hysteroscopies take me 2 minutes, okay? So it's a very short procedure, but I told you it can be very dangerous as well. So how do we keep it safe? We keep it safe by making sure we know our patient well, both in the history, examination, investigation, everything is clear. We keep it safe by having a valid consent. There is an example of a Royal College consent for hysteroscopy, which could be used, or on those lines. We use principles and guidelines of hysteroscopy, and we should have safety checks. We've discussed this slide before, that for us to have or become a great MIS surgeon, we need to understand ergonomics, which I've taken you through. We need to understand engineering, which means you have to understand the equipment and the technology around it. We need to give the task breaking it down into subsets to understand and do it better. And we need to understand anatomy. We've done the anatomy class as well. So what is the engineering around hysteroscopy? Well, it's the table and the OR setup, how we will be positioning ourselves, where will be the fluid distending media placed and how it works, what is the equipment around the hysteroscopy, that is the hysteroscope, and the setting up and the dismantling of the scopes and everything. Then we have the energy. If we're going to use energy, how would we know about it? Do we know about the use of monopolar in hysteroscopy? Do we know about the use of bipolar in hysteroscopy, etc.? And then you have your vision cart, which is us understanding how are we going to be observing on the screen so that we know what's going on inside, which is the left, which is the right. So you see that kind of thing. So this is basic OR setup. What are the instruments around hysteroscopy? We have the telescope, which is similar. We have shown you in the theater. We have a light source. We have diagnostic and operative sheets of the hysteroscope. We have the distending media. Most of the distending media we use today is fluid. And the fluid we use mostly is normal saline because it's isotonic. It does not give us issues with electrolyte imbalances. So very important. We use camera and we have accessory instruments that we would use. So the telescope, we have, obviously we've discussed this, but we have the eyepiece, the barrel, the objective lens, etc. And the angles that we have in hysteroscopy could be 0 degree, 12 degree, 15, 30 degree, 70 degree. The ones that we use mainly, that I use mainly, would be 30 degree or a 12 degree. So a 30 degree is very good for diagnostic because it lets you see angles that you don't normally see without moving around much. And the 12 degree, and it can also be used in cold Caesars or cold surgeries. But a 12 degree is excellent for resectoscopy, where we use energy. So please understand, 12 degree for resectoscope and energy-related procedures, whereas the 30 degree is very good for diagnostic and possibly cold surgery. A 0 degree would give you a very good panoramic view, but angled views are very important. That is the 30 and 12 degree for viewing the ostia in especially abnormally shaped or positioned uteruses. Then we have a rigid hysteroscope and a flexible hysteroscope. We usually work with rigid hysteroscopes, which actually is more durable and provides a superior image, 3 to 5 millimeter diameter, and it can be used even in more complex operating room procedures. Flexible is usually also can be used, but it's more used in diagnostics because it's finer, it's more fragile, and it can obviously be flexed around the tip to up to 120 to 160 degrees. So this is what we mean by how we would get a 30 degree and a 0 degree scope work. So you can see here, this is 30 degree, 0 degree, where it's showing you flat. So in this scope, if I was to look at this side, I'll have to move the whole scope this way. You've understood? Which now makes it difficult because your cervix is holding the scope. So when you're doing this, you're having a restriction of movement. Whereas if this is 30 degree, you see it's showing you at an angle just directly. So when my cable goes this way, I'm seeing that way. When my cable goes opposite, I'm seeing this way. When my cable goes down, I'm seeing the top wall. And when I now move the cable completely up, I'm seeing down. So you see, you can see all the 4 walls very clearly by only moving the cable as opposed to moving the whole scope around. Got it? So that's why a 30 degree scope is very good for looking all around diagnostic. Now we go into the light source. We've discussed this, but just a quick overview. I told you we started with the original, which was the tungsten lights and the filaments. Then it moved on to halogen. Then it moved on to xenon. Then it moved on to LED. Right, which is the latest one that we nowadays use. The camera, we've discussed this. The cables, we've talked about it. I've shown you these cables, the fiber optic cables and the gel cables. The one we use are the fiber optic cables. You've seen the inside. When we talk of energy sources in relation to hysteroscopy, we have the monopolar as an energy source. We have bipolar as an energy source. We have resectoscope, which again can be either monopolar or bipolar. And we have the laser that can be used. So we go into resectoscope. The resectoscope consists of an inner sheath and an outer sheath and an electrode as well. So we have the inner sheath, which is going to be sharing the channel with the telescope, the distending media, and the electrode. So what we mean by that is you have a sheath that you put your scope in, and the same scope, the same sheath also has the fluid connection for in, and that's where the operating instrument, in this case an electrode, will be going through. So similar to the regular hysteroscope, where the inner sheath is the one that has the port for the fluid, it has the port for the scope, and it will also be the one where the instrument goes through. Then we have the outer sheath that actually has the fenestrations and the outflow of the fluid. So you have an outflow and an inflow. Then we have obviously the lens or the scope, which we know it is angled, and I told you for resectoscope what kind of degree of scope would I use? A 12 degree. Why exactly? Because see, your electrode is straight, right? Now, if I go with a 30-degree scope, I'm seeing 30 degrees away. The tip of the electrode cannot turn 30 degrees. It's rigid, it's straight. So if you're seeing very far off, when you're trying to, let's say, resect this part, you will need to be close to the view. Now, if I put it 0 degrees, then I'm looking at it straight on. I won't be able to see the pathology and my tip of the instrument. So what I want to do is come up a little and see it from 12 degrees. You've understood? As I'm cutting. Now, if I go too far off, 30 degrees, I'll be able to cut here, but here it's going to be very far from me because my instrument is here. It's straight. It's never going to be going 30 degrees down. So if I'm seeing the pathology at 30 degrees, but my electrode cannot go to 30 degrees to cut it, I will struggle. So try not to do, you can put in the scope and see, but when you try to resect, you'll realize, okay, I'm struggling here. Why am I struggling? You'll be struggling because you're using a 30-degree scope on a resectoscope. You've understood? Where your electrode is rigid. So how you can't turn it and you're viewing something different. So that's where you'll get stuck. Now, these electrodes could be a loop, could be a knife, could be a barrel or a roller ball. So this is now for the buzzing. And the common sizes for resectoscopes nowadays, obviously, there are many that are also called mini resectoscopes, which are much smaller. So 15 French, but 15, 16 French, but we have 22, 26, 29 French as the routine. And how do you convert French to millimeters? You divide by 3. So anytime you've heard of a French, okay, you divide by 3 to get the diameter. We get French in Foley's catheter, size 14 French, 16 French. You know that, right? So if you want to know the diameter, divide by 3. Okay? So a 14 French is 4.8, 4.9 millimeters diameter of that Foley's. 18 French is a 6 millimeter diameter. You understand? So that's how you divide French into millimeters. Okay? So this is what we were talking about. This is the full hysteroscope that has your scope with its light adapter. This is the resectoscope, sorry. It has the handles with the inner sheath and the outer sheath. Then you have the fluid in and the fluid out. You will also have the loop, which is the working element inside here, okay? So this is the working element and then the electrode. So this is basically a resectoscope that you would do. I told you the telescope, see, it's already written 12 degrees. So it's almost understood that when you are talking of hysteroscopy, you should know that the scope I'm going to use is a 12-degree scope. Where can we use the resectoscope? We can use the resectoscope with energy on doing fibroid resection. We can use it for shaping or removing the septum. You can use it for, that's metroplasty. You can use it for septum resection. You can use it for polypectomy. And sometimes people have used it in Asherman syndrome, although I personally don't prefer energy in an Asherman's uterus. All right, so Asherman's uterus is already damaged. You use energy, you may damage it a bit more. So, I mean, it will open the cavity up. There's no problem. It will be very good because there'll even be no bleeding. But you know the problem? The problem is Asherman syndrome already has damaged endometrium. You get what I'm saying? Endometrium. There is very little endometrial tissue in Asherman syndrome as it is. It's thin and it's damaged because where it was stuck, there is no endometrium between that. That's why it got stuck. So this is myometrium stuck to myometrium. You separate it and you use energy, then again, you damage the base of that burn. So you don't even allow this endometrium to probably overgrow it. So trying cold scissors dissection in syneculitis is better than energy. Got it? So this is, Asherman syndrome. I mean, we can use it for myomectomy. We can use it for cervical polypectomies and other endometrial polypectomies. This is what a normal uterine cavity would look like, where ideally speaking, from around the internal os, when you look at it in a panoramic view, you should see both ostia there. If you don't, that means it could be going like that, which is like a T-shaped uterus. You may need to correct that uterus. Those uteruses that are called T-shaped uterus or uterus infantilis, which is also a smaller size uterus, have more challenges with pregnancies. So they usually end up with miscarriages. So a little correction of that, and they even have challenges with fertility. You correct that, and frankly, the outcomes change dramatically. We have Asherman syndrome, where we have the synechia. We could use it for a septum that we use to correct. So this is two cavities with a septum in between. You have to differentiate and be very sure that it's not a biconvate uterus. If it's two horns, that's biconvate uterus, right? Or it could be a didelphys uterus all the way down to the cervix, or even two cervixes. Or you could have a septum. Now you can resect the septum, but you can't go and just resect a bipolar. You'll open up the cavity. Open up and perforate. So you have to be able to differentiate that preoperatively. So I told you, know your patient well, work up the patient well, use things like even a good ultrasound or MRI or a 3D scan, 3D ultrasound, to actually differentiate the two before going in to say, I'm going to resect this septum. And all you know is it's a biconvate uterus, got it? So we've discussed about this. So what are the few principles that I would say you should know about hysteroscopy? Now, hysteroscopy is a topic that I could probably divide into almost 8 to 10 subtopics for you. But I don't think we will have that kind of time to go into all the details. So there is the introduction, there is the history, there is the principles that I usually teach my patients, my doctors on. Then there is the anatomy of the hysteroscopy. So you should know what is the normal anatomy of a uterus and what are the abnormalities that you can come across, including pathology. Then there is fluid distension media. How do we do it? There is the actual demonstration on the equipment itself. And then there is also complications of hysteroscopy. Then there is what is challenging hysteroscopy. So maybe challenging hysteroscopy, I'll take you through if there's time now. But challenging is not every case will be straightforward. So how do you come across and deal with those challenges whenever they happen? Okay. I told you hysteroscopy, frankly, is a short procedure, but a very dangerous procedure. I'm repeating it again. Very likely to cause complications if we are not careful. So, a few principles to avoid those. Number one, the uterine cavity pressure. So again, that's another demonstration I normally give, the actual settings. Hysteroscopy, you need to know the settings, and there is no alternative to it. There is no shortcut to it. You should know how to play with the fluid and the settings so that you are always safe. So the uterine cavity pressure. So what are the settings before we go into that? The settings are, number one, the maximum preset pressure, intrauterine pressure. Okay, so it means you'll go and put the setting that I want my hysteroscopy fluid to distend this cavity to a maximum pressure of this much. You've understood? Now, why is that important? It's important because you need to understand a few things. If this is the cavity, if this is the cavity, you have to understand a few things. There are a few valves that maintain this uterine cavity. Okay? One of the valves is the external os. This is a major valve, the internal os. This is another valve, the ostium. And this is another valve, the femoral end. Make sense? So for you to be able to see this cavity, because your interest is this. Your interest is not this. Okay? Your interest is this. When you want to see this cavity properly, you have to have this area passed or gone through, but you have to ensure that this area is preferably not opened up. Are you getting it? Because otherwise, all your fluid will just flow out. So you'll have a lot of fluid, intravasation into the abdominal cavity, and you have a higher chance of fluid overload. But at the same time, your view might also be compromised if all the fluid is just being pushed away. So that is what we need to understand. How much do I distend this area so that the fluid remains inside, not too much going outside. It will go outside, but not too much. And I get a good view. So that is the intrauterine pressure I'm talking about, okay? So you should know what valve pressures these ones open up at. Like this one opens up at around 70 millimeters of mercury. So when you go above 70 millimeters of mercury, you will actually distend the ostium and fluid will go out. This is around 45. Okay? So you want to keep your fluid, if possible, pressures around 70 or below or somewhere there. You get it? But this is just theoretical. So in practical sense, you want to keep your pressure to be lowest necessary, enough to distend the cavity. And the guide we use is preferably below 100 millimeters of mercury. So put your setting max to 100, or work around the mean arterial pressure, MAP, the MAPS. So what is mean arterial pressure? How is mean arterial pressure calculated? Yes. So that is the calculation of the MAPS. And if you look at the monitor, it will give you the BP in the form of systolic and diastolic, but in the bracket, it will give you the MAPS. So you walk around those pressures. That's what I'm trying to tell you, okay? Another principle is use of normal saline with bipolar energy reduces risk of hypernatremia. So what do I mean by that statement? When we discuss fluid, because fluid is of different types that we could use for distending the media, we'll talk on fluid in a while. So when we talk of fluid, then you're talking of fluid that could either be isotonic, like saline, or could be hypertonic or hypotonic, okay? When you have hypotonic, then you have, and you absorb that fluid, you can have a very big problem of fluid overload, yes, but also of electrolyte imbalance, okay? And it can therefore cause lots of other challenges like cerebral edema, convulsions, including death. So it's a very dangerous scenario to have an overload of a hypotonic solution. Same with hypertonic, again, there is a problem because you will get dehydration, okay? Whereas if you take isotonic, the electrolyte imbalance issue will not be there. But what can still remain is fluid overload. So you should know your cutoffs. So number one, know your pressure settings that I've told you. The flow rate can be set at 200 to 400. So flow rate 200 to 400, pressures at or below 100, play around the MAPS, okay? Number three, when you're talking of the volume of fluid used, that's the third important parameter. So for volume of fluid used, for example, for saline, which is isotonic, you are interested not in the volume of fluid used, but you're interested in the deficit of volume of fluid. So what is that? It doesn't matter that I've used 10 liters of saline, as long as I can account for 8 liters of saline as outflow. Are you understanding? So the deficit is inflow minus outflow that you can account for. So if you can account for inflow versus outflow of less than 2.5 liters, patient is safe. So the cutoff value for saline is 2.5 liters deficit volume. Got it? Then you go into the ones for hypotonic solution. So we'll discuss that in fluids. Obviously, another complication, that is perforation. It's not a principle. Now, most complications are entry related. So one of the other things that I have been doing over the last 10 years, I do not dilate the cervix. So you shouldn't dilate the cervix. Because when you dilate the cervix, you are damaging maybe this, you're damaging this, you may go into a false passage, all those things can happen. Agreed? You may perforate. So the approach of choice should be vaginoscopic approach. Vaginoscopic approach. My team knows exactly what I mean by that, and they do it all the time. Vaginoscopic approach means you first enter the vagina and distend the fluid. When you distend the fluid, you will see the vaginal wall. So you can also do vaginoscopy and say, okay, this wall is fine. This is the rugae. What is this small nodule here? Why is there this vaginal polyp? You get what I'm saying? So you're doing a vaginoscopy. And then you're seeing the cervix there. You see the anterior fornix. You see the lateral fornix. You see the posterior fornix. Then you go behind and see if there are any, like if I do endo, if there's any nodule on the posterior fornix, those sort of things. and then you go into the uterine cavity. You've understood? Under vision. Now, once you enter into the uterine cavity, you follow the track of this. So whether it is anteverted, retroverted, irregular, it doesn't matter. I'm following the view, and I'm pushing only when I can see. When I don't see, I'll stop again, I'll look around and then say, okay, here. Then you go ahead. If there's stenosis, doesn't matter. I have an instrument that I go in with the scissors, and I would cut what I can see and then proceed. Cut and then proceed. So it's under vision. Number one, risk of perforation is very little. Number two is you can handle those kind of challenges like Asherman's or stenosis of the cervix, or a growth there, or an obstruction there, or an irregular cavity easily by vaginoscopic approach. So you should all be trained in vaginoscopic approach. It should not be direct. Well, how do you sometimes avoid complications? So we'll discuss this, I think, a bit more later. So what do you need to understand about hysteroscopy? Number one, hysteroscopy is a one-man show. Okay? So hysteroscopy is a one-man show. What does that mean? In hysteroscopy, my dear, the surgeon is the one who is holding the camera and operating. There is no assistant helping him. Okay? It's a one-man show. So you have to be careful, everybody's watching you. All right? In laparoscopy, when something goes wrong, you can put it on the assistant and say, they were not helping me. In hysteroscopy, there is no assistant, it's you. So it's a one-man show. You mess up or you cause a complication, it's you. Two, entry can be challenging. So you have to understand that how am I supposed to take care of these challenging entry scenarios? You need to typically understand technology about hysteroscopy very well, because it has a very narrow safety margin. I've told you it's dangerous. So if you're not careful, you can easily complicate matters there. You need to understand fluid distending media and its issues around it. It is a very small cavity. The uterine cavity is actually a very small cavity with lots of pathology. So you can imagine you have a very limited space to play around with in hysteroscopy. Okay? Whereas the same in laparoscopy is different. You have a whole abdominal cavity. And at any given time, usually you only play with one instrument at a time. So it's like trying to operate as a one-handed surgeon. In laparoscopy, I get a bit upset about anyone trying to do one-handed surgery. So you're trying to cut that and you're just pushing with that and cutting it. And so it's a one-handed sword type of surgery, very bad. You have to be holding, cutting, pulling, cut, hold this way, lift, cut. So you see, you're working with two hands. We understand. In laparoscopy, it's two-handed all the time. If you're assisting me and you assist me with one hand, ask my team what happens. I get upset. Okay? You should be able to understand that surgery in laparoscopy is two-handed. Surgery in open surgery is two-handed. But surgery in hysteroscopy is one-handed. Yes, I'm still using two hands, but what I meant was one is my view and only one is my operating instrument. That's what I meant by one hand. I'm not saying I'm not still going to be doing this. I'm still doing it with two hands, but my operating instrument can be handled with one hand. You've understood what I'm saying? I can't have my assistant hold the camera and I say I go in with two instruments. It's a bit difficult. One, there's no space in there, and two, it's cumbersome to have two instruments in there. These instruments are very fragile. You have to understand that. Hysteroscopy instruments are usually 5 French instruments. So 5 French instruments in millimeters would be 1.6 or something, 1.6, 1.7 millimeters. So imagine how thin they are. It's very easy to break them, to bend them, to damage them immediately. So if you don't know how to use them, you'll damage them. It's very easy to get obscured vision. Something comes in front of the scope. It's a very narrow cavity. A blood flake or bleeding happens and your view is gone. All right? So it's not easy to work in hysteroscopy with vision that is blocked. So even if there's a bleeder in there, you will suddenly see a red round flag. So your whole scope will become red. You've understood? So you have to know how to proceed from there, because that's what we call Japanese flag effect. If you have seen Japanese flag, it's a red circle in a white. Well, that's what you will see, that you have your screen and suddenly your scope is just red. Now you have to be careful with that, because you can't operate when you have a Japanese flag effect, okay? There's risk of leakage. So you have to understand hysteroscopy and that there is leakage. So you can't over dilate the cervix. You over dilate the cervix, now you put in your scope, fluid is just going to leak out. What are you going to see? Nothing. That's why I'm saying I don't dilate as well. You go in with a scope and you follow the trend and you will have the view properly seen, because this thing is holding, it's gripping over the cervix. You get it? I mean, the cervix is gripping over the scope. So you will see better if you don't over dilate the cervix, okay? And the risks in hysteroscopy can be dangerous. You have to understand that. Thank you. So we move on to hysteroscopy media. So it's very important to understand media as well. So good morning again. Let's talk about hysteroscopic media. So when we talk of the media that we use, we'll classify the media. We'll understand the properties and the use of the media. We'll see how to supply this media into the uterine cavity, so the media, the distending mechanism. We'll have to understand the guidelines of the various media and talk a little bit about complications of this media and how to manage it. So as an introduction, the distending media is mandatory to allow visualization of the potential uterine cavity. So uterine cavity is not like an open space that is like this room already. The walls are opposing to each other, all right? It's only when you want to see it, you distend it with something, then you can see what you want. When you stop distending, it closes again. You understand? Because you have to understand the uterus is a muscle. The muscle contracts, so it's always contracted. But you can distend it to see, and then it does that again. So it's a potential cavity. We have to understand that because it's a potential cavity and you're distending it, when you're distending it, you can get absorption of this media through the walls of the uterus, through the openings of the ostia, through the open vessels that could be there. You've understood? Through a wall that you are now going to be cutting. Let's say you're resecting the fibroid. When you cut in, you will push fluid through there. So this is a problem that you have to understand about the media. And it's more risky in operative procedures than diagnostic procedures, where you're causing a break in the endometrial myometrial junction. So the moment you go beyond the endometrium into the myometrium, you're opening up vessels. Got it? And this surgery can be done in hysteroscopy using cold scissors, graspers, energy, electrosurgery. Okay? The normal osmolality of plasma is around 280 milliosmoles per liter. So we divide media into two types broadly. One is gas media and liquid media. Gas media has been used in the past in the form of CO2 gas, mainly for diagnostic procedures. It's difficult to operate in the gas, okay? So these days we do not use it. It is of theoretical knowledge that you need to know, but we don't use it anymore. So we go down quickly to liquid. In liquid, We can have high viscosity or low viscosity media. High viscosity is also hyperosmolar. So it's thick. It's like gel-like, a little bit thicker. And the one we have is dextran 32 and Hiscon. But again, we don't use much of it. I've never used it. And you will use a little of it because it's a little thick. It's like gel. You get what I'm saying? So you can see it, but it's difficult to operate in because when you cut or something, the blood may not mix with it, but the fluid is, that liquid is not easily drained out. So it will remain there. You've understood the blood with all the tissue and everything. And the risks of hyperosmolar solutions might have to be kept in mind. The second one, we have low viscosity, which is thin fluid. And we can have isotonic or isosmolar solution and hypotonic or hypoosmolar solutions, okay? So iso is matching the 280 milliosmoles per liter solution. Got it? So we have these that are iso. You can see their osmolarity is similar to plasma. Got it? So you have saline, 0.9%, that's the normal saline. You have Ringer's lactate, and you have mannitol, okay, 5%. But mannitol has no electrolyte, but these two have electrolytes. So we have Ringer's lactate or normal saline. The commonest one that we work with is normal saline. And that's the one that I would say you all need to know in depth, because I don't think you're going to be using any other in the future. These are for understanding, but it's all going to narrow down to only one, okay? Then we have hypoosmolar. Again, these are not electrolytic, or if they are, then they are under the normal osmolality of the solution, of the plasma. So you have glycine, sorbitol, dextrose, etc. Again, you need to understand them and know the complications, but we don't usually use these anymore. I don't use them anymore. Let's put it that way. I know they still can be used, but I don't use them anymore. What is an ideal medium? An ideal medium should be able to give you a good view. So an ideal medium, number one, should be colorless. Agreed? If you have a fluid that is colored, if you use milk, just give an example. How will you see anything in milk? You've understood? So it has to be clear, number one. Number two, and it should be able to give you a good view even with bleeding, because you're going into a cavity where it's going to bleed into the solution, right? So even with bleeding, you should be able to wash it out and get a clear view again. It should be readily available, something not that you'll have to start importing from Japan every time you want to do a hysteroscopy. Some things are not available, right? So you can't have that kind of a medium to use for your regular scopies. So you'll want to look at something that's available, preferably isotonic, obviously non-toxic, hypoallergenic, so something that you don't have to worry about, will it cause an anaphylactic reaction, etc., etc. So you don't use something with proteins and all that stuff. The moment you use something with proteins, you're also risking allergy. It should be non-hemolytic. It should not cause hemolysis. It should be cheap, and it should be able to allow operative work. You see, so if I look at it from all these angles, and it should be safe. So if I look at it from all these angles, then I think one stands out, and that's normal saline. Okay? So we said CO2 was good for diagnostic, not for operative work. You would get a very poor vision in the presence of blood, and the insufflator used would be different. It's not the same one that we would use for laparoscopy. Glycine, well, it is hypoosmolar, hypotonic. It's electrolyte free. It has an osmolarity of 200 milliosmoles. But the risks with it is a problem. Sorbitol is hypotonic. It's also electrolyte free. It has an osmolality of 165. It can cause hyperglycemia and hypocalcemia in addition to the issues with osmolality. Okay, so osmolality and electrolyte imbalance is one of them. Then there's hyperglycemia and hypocalcemia as another effect. Dextran 32 is high viscosity, hyperosmolar, and you would have an issue with how much volume you can infuse. So it now means that we are mainly talking about saline, right? So the next discussion, once we have narrowed down to saline, is how do you supply this fluid into this uterus? Okay, so one of the supply would be by gravity. What does gravity mean? Hang a saline bag up there and let it just flow. Yes, it will work. You've understood? And if you hang a 3-liter bag at around 90 to 100 centimeters, which is a meter above the pelvis height, so the patient is lying here on the bed, and you put it at this height. All right? Not the bag is here. The bag is here. I mean, even our IV stands, the bag is here, right? So when you put it at roughly a meter above the height of the patient, it will give you a pressure of around 70 millimeters of mercury. So I told you the 70 is a good flow, pressure for you to do a diagnostic hysteroscopy and all that stuff. So it's a good pressure. You can work with it. So if you don't have a fluid distending agent or mechanism, in this case the pump, then you can work with this, but mainly for diagnostics. Okay, you can't work with it for operative. It's a bit difficult. The second thing is you could use the same bag and then put a compression cuff on it. So what does that mean? They are those like BP cuffs that you could put, and it has a cuff around, and then you pressure. So you do that, or you press like this with your hand and push it. So this is manual pressure. This is compression pressure with the cuff. Understood? So if you set it at around 80 to 120, then it will give you. But again, the problem is the kind of hysteroscopy work we do ideally should be what we call constant pressure, variable flow. Constant pressure, variable flow hysteroscopy. Okay? So what does that mean? At any given time, if you've put your setting at 70, you want to, or 100, you want your pressure always to remain below 100. You've understood. If it goes low, more fluid is pumped in. If it goes higher for some reason, because there's a block everywhere and fluid is now just distending, the fluid should stop going in and just allow it that way, because it's already giving you a good view. You've now understood. Constant pressure, variable flow. When you do this one with the compression cuff and the bag, what you're doing is you're doing constant flow, but the pressure will be variable. Are we understanding what I mean? So once you have put a pressure cuff on the bag, it's going to keep on pushing the fluid at a constant flow. Are we understanding? Now, if this cavity is already distending and it's still distending, you are still pushing in whether the pressure inside there has reached or not, it is constantly still pumping in. And if you suck out or it's leaking and it's compressed, it's falling, this is still putting constant flow. It's not increasing the flow when the pressure down there has reduced. Are we understanding each other there, guys? So the problem with this mechanism is it will not give you the constant flow, constant pressure variable flow model. So again, it is not very good for the type of work we are doing if it is going to be operative and prolonged, okay? So next, Therefore, you have something called the microprocessor controlled irrigation and suction pump. So they have been used as different names. We have the Histromat, the Endomat, etc., etc. Okay? So this is a microprocessor controlled irrigation suction pump. So microprocessor controlled, meaning it is sensing the pressure. So if the pressure increases beyond the preset that you've put, the flow stops. If the pressure goes down, the flow increases. But it's trying to maintain that pressure. You now get my point? So it maintains a constant intrauterine pressure and adjusts flow according to this. So if you set your irrigation pressure to around 50 to 80 or below or around the maps, as we've said, and then you put in your flow rate to be 200 to 400, it means when the pressure is high, it will even come down to 0. But when it is low, it can push in fluid at a rate of almost 400 ml in a minute. So if it's collapsing, the cavity is collapsing, it will suddenly push in and make it distended. So at least it will give you a good view throughout the procedure. Now are you understanding that? So you should try aiming at 30 to 40 millimeters of mercury intrauterine pressure to give you a good distension. So remember the internal os and then the ostium. So 40 to 70. If you keep it between there, and that's what this pressure will do. When you say I'm setting it 100, it doesn't mean it's giving you 100, but it's going to keep it below 100. It's the maximum. You've understood? So this is what you will be setting at. So these are the valves I was talking about. The external os, the internal os, the ostium, and the fimbrial end, right? So what is our problem with this fluid distending media? We are worried about mainly the absorption, isn't it? That's the main issue. We're worried about absorption. And how is this fluid absorbed? It can be absorbed retrograde into the abdominal cavity through the tubes. So if the pressure is too high, it opens up the ostia and the fluid goes out, especially in patent tubes, isn't it? So it'll go out. The second one, it will get absorbed through the endometrium because it's a direct contact and it pushes it in. Or if you open up the myometrium through those major vessels that are in the uterine cavity, through the vessels. So this is how this fluid is getting absorbed. When does it happen? When your pressure setting is high, when your BP of the patient is low, so the maps are low, so even if you put it at a normal pressure setting, because the maps are low, the fluid will still go in. You've understood? Then when you're going deep and you're resecting the myometrium, you should not resect the myometrium in most scenarios, okay? When the surgery is very prolonged, the longer you take, the more the risk of fluid. I told you in a normal hysteroscopy, diagnostic hysteroscopy, I do it for all my patients. I don't take more than 1 to 2 minutes. All right. And even in operative procedures, I don't take more than 15, 20 minutes. But this is my figures now after so many years. I know people can be in there for 45 minutes to an hour to 1.5 hours doing hysteroscopy. Trust me, if you're doing that, you are overloading that patient by the duration you're taking. Okay, it's not right. And the size of the uterine cavity, when you have fibroids and all that stuff, there are very many. The adenomas, the uterine cavity is bigger, so you have a higher chance of absorption. Okay. Fluid overload. This is your problem. So when you get fluid overload of more than 1,000 ml in a hypotonic solution, that's an overload issue. The rule is you reach a deficit of 1,000 ml in hypotonic solution, stop the procedure, reschedule the procedure. Do not say, I have 5 more minutes to complete. my friend, you will land into problems. Okay? So know when to say stop. In saline, it's 2.5 liters, 2,500 ml. Stop the procedure. I mean it. Stop the procedure. Terminate the procedure. Okay? And then reverse the patient, let her recover, talk to her later, tell her we will do a second procedure, second sitting. It's allowed. But you're safer that way than to deal with the overload issues. If you have an elderly woman or a woman with comorbidities like cardiovascular issue or renal issue, then your cutoff are 750 and 1,500 ml respectively for hypotonic and isotonic solutions. Make sense? So it's no longer 1 liter and 2.5 liters. It's 750 and 1,500. The incidence is less than 5 in operative cases, less than 5%, but that is if you follow these rules. If you don't follow these rules, you can be one of the masters of causing fluid overload every time you operate. So it's up to you. You want to be a master in that or not is up to you. What are the nature of complications that we can get? For hypotonic solutions, you will get neurologic issues as well as cardiovascular issues. All right, neurologic issues because of the hyponatremia, cerebral edema, neurologic impairment, seizures, including death. Cardiovascular because of hypovolemia, pulmonary edema, heart failure, etc. Whereas in isotonic solutions, you're only going to have cardiovascular effect, not the neurologic or electrolytic imbalance issues. Got it? And the premenopausal women are slightly higher risk of neurologic complications than the postmenopausal women due to suppressive effect of estrogen on the ATPase pump that we have. So you will have a higher issue with neurologic complications in younger women than in older women. Okay? What are these? How do you know? Well, you will develop them when the sodium falls below 125 millimoles. The normal value is 135 to 145. So when it starts dropping, you can start getting these complications. The patient may get headache, nausea, vomiting, generalized weakness. And if it further drops, you'll start seeing effects on brain edema and increased intracranial pressure. They'll get agitated, confused, even get some blindness, temporary, and severe headache. And when it now goes below 120, this patient may get confused, lethargic, get a seizure, go into coma, may get bradycardia, and an arrest. So these are extreme complications that you don't want to go across. When it's cardiovascular overload, what do you get? You'll get pulmonary edema with low SpO2s and crepitations, which we can know, and you know how to deal with it. Give them oxygen and give them a diuretic, okay? And it will clear up that over time. You can go into CCF as well, congestive cardiac failure with tissue edema, poor oxygenation of the tissue, and pedal edema. How do you manage these? Obviously, this is the way to manage it. I'm not going into the management because my job as your teacher is to tell you how to prevent it, okay? Not how to handle it. When it comes to handling it, let it be handled by a multidisciplinary intensivist team because these patients are going to be very sick, okay? So, the medium of choice, therefore, we now know isotonic media is safer than hypotonic media. We know the fluid deficit should be closely monitored in either case anyway. For diagnostic cases, saline or CO2 can be used. For monopolar resectoscopes, if you are going to use monopolar, then you only need to use a hypotonic solution or a non-electrolytic solution. If I use monopolar on saline, what will happen? Anybody? Electrolytes, I mean, saline has electrolytes, okay? It has sodium, it has chloride. If I use electrolyte, I mean, energy in that, monopolar energy. What does monopolar energy require? It requires a return plate to take the fluid out, right? I mean, to take the energy, electricity back to the machine to complete the circuit. So it means when I use saline, I will be pushing in electricity into the patient, and then it will be looking for this return plate and wanting to go back to the machine. So what will happen is I activate monopolar inside a patient in the uterus with saline. Anybody? If I put saline here, a pool of saline here, and I connect a cable into the into the circuit here, and I put the wire here, and I tell you step into it, what will happen to you? You'll get a shock. Excellent. What will happen to this patient if I now put in saline in the patient and I put electricity through there and there is a return plate? Anybody? Huh? Yeah, that's exactly the answer I was looking for. But that will never happen. So that is where energy needs to be understood. That's not what will happen, sir. But that's what people think. And they say, I will never use energy in saline. Why? Monopolar energy in saline. Why? Because it will burn the patient. It doesn't burn the patient. Actually, it protects the patient against any burn. Why? Because for you to cause a burn with monopolar, you have to concentrate your energy into one spot, and then it goes there and it burns. And then this is the return plate where the same energy is now dissipated across a big surface area. So big surface area, no burn. Small surface area, burn. Are we understanding? That's what happens in our surgery when we used the pencil, the monopolar pencil or whatever, you know, right? That you burn here, it will burn, and then here it's returning. You're not reducing how much energy is here and how much energy is here. What you have done is small surface area, big surface area. Are we understanding? This does not burn, this burns. So when I put saline and I activate it, what is saline doing? It's increasing the surface area, because wherever the saline is touching, electricity can pass through everywhere. It's not one spot. So if I go this way and I now take saline all over here and I touch it here, all right, what will happen? It will dissipate into the saline and across the surface of the uterus that it's touching. The saline is touching everywhere, including the vagina, including, it's all continuous, right? So what will happen? It will never work. Why? Because you will never get a focus in one space to burn. Have you now understood? It's just spreading out. So saline in monopolar is not used because it will not work, not it will burn the patient. All right? That's what I wanted to clarify, guys. This is different. What I showed you on the floor and that's a different scenario altogether. But that is different. You've understood now? Now, in non-electrolyte solution, which means there is no electrolyte, the fluid is distended by glycine or sorbitol, there is no electrolyte. It cannot dissipate the electricity. So now I go in with a hook and I cut like this, it will cut. And then it will look for this return electrode to go back. Have we understood? So it will only work in non-electrolyte solution. In electrolyte solution, it will dissipate, it will not work. So it's not, it is dangerous, it's not, it will burn, it will not work. Are we clear? Good. So it is no effect, okay? And in bipolar resectoscope, you use saline. So that's why the new resectoscopes are all bipolar, because you don't need to worry about using the non-electrolyte solution and then getting the complications with that. Use a bipolar resectoscope with saline. You've understood? Good. So safety tips to reduce fluid absorption. 1 pre-op GnRH analogs in premenopausal women before TCRF stands for transcervical resection of a fibroid. So it's hysteroscopic myomectomy. Let's put it that way. So before hysteroscopic myomectomy of a type 1 or a type 0 fibroid, you would give this patient maybe something to thin the lining. Or you plan it in the first half of the cycle when the lining is thin. You can't do myomectomy when it is very thick lining. You'll not see the fibroid. 2, use of intracervical injection of very dilute vasopressin. You have to be very, very careful with this. This thing can cause a sudden, cardiac arrest. So it'll cause bradycardia and cardiac arrest if you're not careful. It has caused this many times in many people's cases. So learn how to use the vasopressin if you have to ever use it, okay? But it's used, and when it is done that way, you will reduce your intravasation of fluid, okay? Maintain the intrauterine pressure as low as possible to give a good adequate visualization, and try to keep it below the maps. And I told you 70 to 100 would be good. And preferably try and use a pressure and flow controlled mechanism, the way we discussed. Don't use saline, don't use manual pressure, don't use bags. For operative work, that's a bit dangerous, okay? So you might have to invest in this and know the settings that I told you. Have a good system to manage the fluid in and out. So it means every 10 minutes, a nurse should, in ideal situation, I'm telling you what is ideal, guys. There's one nurse whom you dedicate in that theater to fluid, okay? And that nurse is looking at fluid, that nurse is monitoring in and out, that nurse is calculating, and every 10 minutes or so is updating the surgeon team that right now, 4 liters of saline used, negative deficit at the moment is 500 ml. After another 10-15 minutes of the surgery, right now 6 liters used, negative deficit 1.2 liters. So you know you're heading towards 2.5. When she says, right now, doc, 8 liters used, I'm missing 2.5 liters. Cut off the procedure. End of story. So you get what I'm saying? That is how it should be ideally done, okay? Therefore, use drapes that can collect. Don't use drapes that can absorb too much, because again, how do you measure drapes that can absorb? So when you're doing operative work, you know that underpad, the surgical underpad, that is like pad material, that it just absorbs a lot of fluid. No, it's not good for operative work. It's not. You have to turn it the other way around so that actually the blue part is on top. So the water just flows into the basin, not absorbs. When you absorb, you don't know how much is absorbed in that blanket of yours. How do you calculate? How do you calculate? So operative work, you should be doing it the other way around. Are we understanding, Joy? When I'm going to do something like polypectomy or myomectomy, this underpad turns this way, not this way. I don't want the fluid to be absorbed. That's not what it's meant for. Okay? Good. So that I can count. The reason I don't, because I don't take that long. I'm done in 15 minutes. But if I am to do a complex procedure, then if the fluid is, if the underpad is that way, I can calculate. If the underpad is white on top with that material that just absorbs fluid, how will I know how much has been absorbed? How will I calculate? Think about it. Automated fluid management systems are more accurate. How do you get fluid volume infused? So you have to see how much fluid went in through the bag. So all those bags should be kept and say, 2 liters, another one, 2 liters, another one, if you're using 2 liter bags, or 1, 1, 1, 1. So you count 1, 2, 3, 4, 5, 7 bags used, 7 liters in. Okay? Then you would say, my fluid from the outflow that is connected, it's going into the bag. The one that is dripping down into the basin down there. Sometimes you have a whole lake that forms down there on the flow. There is a way someone should be constantly collecting that and putting into a measuring jar and saying, okay, this is 100, this is 500 ml. So you have to be able to measure your deficit, okay? And I told you it's done by one dedicated team of the member. And you have to be doing this at minimal intervals of 10 minutes, okay? Thank you.